Hello there. My name is Mihir Naik, and I'm a radiation oncologist here at Cleveland Clinic, Florida. I learned about this organization as I was invited to come and talk a little bit about the role of radiation, but as I read more about the organization and all the resources they provide to patients, it's been quite wonderful. I honestly can't imagine seeing a patient with this diagnosis and not referring them to this organization to see the resources that they have and the support that they can get. So it's an amazing organization. I feel privileged to speak here today. I'm going to talk a little bit about the role of radiation treatment for gastric cancer. Don't have any conflicts of interest to disclose. Briefly, we touched a little bit about how common it is. It's still, unfortunately, a common diagnosis. There are about 28,000 cases, and unfortunately, nearly 11,000 people die every year as a result of gastric cancer. And worldwide, this is even a more common problem. It's the second leading cause of death, cancer death worldwide, outside of lung cancer. And as many of us probably know here, there is a regional variation in certain countries having a higher incidence of gastric cancer, such as Japan versus being a little bit less common in the United States. And it's also correlated with socioeconomic status. There's the role of radiation sort of initially got established by a large trial called the McDonald Regimen, or the intergroup study, where they took patients with locally advanced gastric cancer as well as GE junction cancer, and they all had surgery up front, and they all had surgery with a negative margin, meaning no cancer cells were left behind. And half those patients were just observed, and then half the patients got initially a cycle of chemotherapy, followed by chemoradiation for a period of about 5 weeks, followed by additional chemotherapy. And this study showed that radiation was able to improve both the overall survival of patients as well as reduce the risk of cancer coming back, what we call relapse-free survival. Or given a lot of this, using the technology we had at the time and stuff, unfortunately, this sort of treatment, while it helps people live longer, is associated with significant sort of hematologic toxicity and significant GI toxicity. And we'll come back to this study as I build on it a little bit more. This is another picture showing sort of the blue curves on the top show that when people got chemotherapy with radiation after surgery, that people were living longer. And what's highlighted in red said that because radiation is, in a sense, is like a local treatment like surgery, where we decide to aim that treatment, we're really able to reduce the risk of something coming back in that area, what we call a local recurrence, or what we call a regional recurrence, which is like, I think of it as like the ballpark in the area around where the tumor used to be. The largest study, which really gave us another very good treatment regimen for gastric cancer, was the MAGIC trial. And this took patients, in a sense, before they ever had surgery. They were diagnosed with a locally advanced gastric cancer, and half those patients still went directly to surgery. Another group of patients, the other half of the patients, had chemotherapy before surgery. They all had surgery, and then they went on to get some chemotherapy after surgery was done. This study also showed that people who received chemotherapy before and after surgery had a survival benefit as a result of their treatment, and really all sort of different age groups and people with their diagnosis benefit from getting chemotherapy prior to surgery and then afterwards. So this gave another treatment regimen versus like where I previously spoke about, where everyone has surgery up front. One of the critiques in the role of radiation treatment has been, okay, we see that people had surgery, we see that there was a benefit in reducing things coming back in the area where the tumor used to be, but maybe the surgeon wasn't necessarily doing a more appropriate lymph node dissection, really sort of looking in that area to take out appropriate numbers of lymph nodes to reduce the risk of cancer coming back. And if people have great surgery, is radiation still helpful to those people? So these are patients with gastric cancer, and they had what we call a D2 dissection, or a more extensive lymph node dissection. And in this situation, half the patients just get chemotherapy after surgery, and another group gets similar sort of treatment with different drugs, where they get chemotherapy first, chemotherapy with radiation treatment, and then a little bit more chemotherapy. And the overall takeaway was that while there was not a survival benefit for incorporating radiation treatment for these patients, there was different subsets would say maybe that radiation could be more beneficial if we think that there's lymph nodes involved, if there's a higher percentage of lymph nodes, meaning, gosh, if someone just took out 12 lymph nodes and 4 or 5 of them had cancer in it, maybe those people would have a stronger benefit to getting some treatment just to the neck of the woods from when the tumor was removed. And we think that there are certain subtypes as well saying an intestinal subtype that may be more likely to benefit from the role of radiation treatment. And there's an ongoing trial looking at specific patients who have just cancer that has gone to the lymph node to see what the benefit of radiation is in those patients. There's been a lot of studies trying to look at sort of incorporating the two different ways to treat people. So in one group, there's this group of people that get a diagnosis of gastric cancer. They start with chemotherapy, they have surgery, and they get more chemotherapy. And another group the question is, maybe what is the role of radiation if people are all going to start with chemotherapy up front? So this study looked at patients who had gastric cancer, and they were randomized, and it was recently published, where half the patients got chemotherapy first, then they had surgery, and then they got more chemotherapy. And another group also got chemotherapy up front, and then they had surgery. But after surgery, we gave them more local therapy in this area from where the tumor was removed with chemotherapy and radiation. This study did not show that radiation by itself added to helping people live longer, showing a survival benefit or a progression-free benefit. But there's been some concerns about this trial of the ability of patients to get through treatment of chemotherapy or chemoradiation after sort of already having a bunch of treatment before surgery and then having a big surgical resection. In general, there's probably a summary where you could say either adjuvant chemoradiation or giving some sort of chemotherapy before and after surgery are sort of a current acceptable treatment regimens in the overall management for gastric cancer. This isn't something that's as widely done. This is a slide I took from different speakers showing that before people have surgery, even when they're diagnosed, and even if they've had side effects of the tumor when they've sort of presented with their diagnosis, the bodies are usually better able to tolerate some treatment. And so there is some experience looking at doing radiation before surgical resection, and the fact that can people get chemotherapy first? Can they get some local therapy over a few weeks? Can that make it more likely that a surgeon, when they have surgery, is able to get everything removed with a nice negative margin? So there are limited times when we'll do these sort of treatments, and these are some of the studies which have shown that it can be done in a safe way, and we can really improve the chance of having a more successful surgery. People sort of wonder why we do radiation and where we're aiming it, and so a lot of how we sort of figured out where to aim radiation treatment comes from these old studies where people had surgery and then people recurred and they looked back and saw where did the tumor actually come back with respect to where the tumor was. And so those little blue, so sort of dark dots are in a sense people mapped out with respect to a patient's anatomy, where did the tumor come back if someone's tumor came back in that neck of the woods, so to speak. And so from that, people sort of had, in the old days, this is how the radiation was designed. So luckily, technology has gotten a lot better since then, but we would take basically larger x-rays of people, and luckily I trained in an era where I just had to read about this sort of way of treating people. But things were mapped out. We mapped out the liver, the kidneys, where the stomach used to be, where the lymph nodes were that had cancer on it, but it was much more rudimentary in terms of technology that we had to plan the radiation treatment. Nowadays, if someone is getting a diagnosis of gastric cancer and we're incorporating radiation to their treatment, it takes us often, several hours to come up with the modeling of radiation, and then at least several hours to help sort of plan the radiation customized to that patient. Based on where we saw the cancer and the areas at risk, we think things may come back. We slice by slice, draw all the areas, and this is just kind of a representative picture saying these are some areas like lymph node areas where the tumor used to be that we draw out, and it allows us to better customize our radiation treatment plan. Here on the picture on the left, you can see kind of the yellow is where the stomach used to be for this particular representative patient, and the red is all the areas of the body that are getting the higher doses of radiation when we used to treat people, in a sense, with older technology using, say, just 1 or 2 beams of radiation treatment. On the right, you can see that red color has now really sort of shrunk down, and we're better able to model the radiation treatment to the areas that we're worried about. And so hopefully the thought being that this is able to reduce some of the side effects, both as people go through the weeks of radiation treatment and in the long-term side effects as people live with the consequences of the treatments that they've had in the past. I think that's all the slides I had today. I'm happy to take any questions that people have.
Thank you very much. So I'm going to open it now to our discussion part. So the first thing I'm going to do, I'm going to introduce our panel. Thank you very much for that 10-minute presentation. We also have Dr. Botero, who's a radiation oncologist at Memorial Health Network. Thank you for being here today. And as you already know, Pat and Joan as our patients, survivors. So I'm going to open up first to questions on treatment, then side effects, and then I'm going to open it up to the patients as well. So from a treatment perspective, I'd like to ask Dr. Botero, what is the actual objective of radiation for stomach cancer? You know, you have chemotherapy, you have targeted therapy, you have immunotherapy. Like, what is it you're trying to achieve with radiation?
It's kind of, thank you very much for having invited me. For me, has been kind of the new person here in the David Foundation. I'm totally surprised how well organized. So you're going to have me here speaking and not speaking, but all the time. Thank you very much. I would say the radiation, I'm surprised that we're starting with radiation, having the surgeons and the medical oncologists. So I applaud him for having started and opening with radiation treatment. But I would say that radiation is very localized treatment, as he said, local and regional, covering the lymph nodes, covering where the tumor used to be. So basically trying to prevent local and regional control more than systemic disease. And the good news is that radiation is not alone, and combined with a good surgery, and combined with the new kid on the block that is the immunotherapy, we have really big hope that radiation will still play some role in the gastric cancer for local control, local and regional control.
Thank you for that answer. I have a question for Dr. Naik. Can you describe, you're told you need radiation therapy, right? And then as a patient, you're like, oh my goodness, what do I have to go through? So there is what's called a simulation session. So can you describe the session and what patients can expect during that session?
Yeah, that's a wonderful question, because sometimes when people show up in our department, they think they're sort of getting radiation that day, or sometimes people really don't know too much about radiation treatment. And so I guess a couple of those pictures on that one of the last slides, basically, everybody's anatomy is different. Everyone's tumor was in a different location and different lymph nodes were involved. So if we're giving somebody treatment, we need to customize that radiation treatment for that particular patient. So the simulation is the process, and basically it's how we map out radiation for that person's anatomy. It usually involves coming to our department and getting a CT scan done in the position that somebody would be getting their treatment. People usually lie on their back on a table. That's a normal CT scanner. Sometimes we do things where we monitor the motion that people's belly moves up and down during the sort of take into account respiratory motion that can happen. We may give people oral or IV contrast to better see things in the body. And we do a CT scan in that position, and then we make certain marks on the skin, which patients often wonder about. But the marks aren't where we're aiming the radiation. The marks are there because we want to make sure that when a patient comes in for treatment, as they lie on that table every day for a few weeks, that we're accurately able to position people as they first get on the table before we sort of start the treatment. So that process usually takes anywhere from maybe an hour or so that day, but most of the time the daily treatments are a lot shorter. They may take just like 15 minutes or so.
Thank you very much for that answer. Just to invite all of you, I'm asking these questions. These questions were actually posed to us through when you registered. So I'm asking some questions that you all want to know. But in the audience, you have blue cards in front of you. If you want to ask a question, please write your question there or raise your hand, and I would love to hear from the audience if anybody has a question. So if you have a question, please raise your hand. I'll look up and see if we can do that. So does anybody have a question in the audience?
I do.
Okay, please go ahead.
Can you talk about prior to a radiation treatment, there's some do's and don'ts as far as eating. Can you elaborate as to what you need to avoid that could actually impact the radiation treatment itself?
Sure, that's a wonderful question. So sometimes, especially depending on the type of surgery that patients have, they may still have a portion of their stomach left behind. And so much of radiation, I think of it as like a machine shop where you're just trying to basically make sure it's the same every single day as people are coming in for treatment. So sometimes we'll have people not eat for maybe a couple hours or so just before the radiation treatment, which can be challenging because of the surgery that people have. but it's often because we don't want, say, the part of the stomach that may be left behind to be sort of larger on one day or smaller on a different day. A lot of times, if we don't expect nowadays as much of, say, a skin reaction or a rash that develops with technology that we have, but we often have patients avoid putting certain creams or things on top of their skin, because the thought being that that may add to a skin reaction during the course of treatment. If nausea is a concern for some patients as they go through treatment, we may have people take anti-nausea medicine 45 minutes or an hour before each treatment, and we think that can also be helpful in reducing some of the side effects of treatment. So there's a variety of different things, but it's all about making sure things are reproducible and people can get to treatment as smoothly as possible.
Great, thank you. So, Dr. Bottaro, do metastases in different organs respond differently to radiation treatment?
Okay, I think that it's important to talk about radiation, the role of radiation for early stage and for the metastatic stages. I think that in general, for all our cancer, I'm not talking about gastric cancer only, in all our metastatic stage 4, what we call stage 4 cancer patients, I think that in the past, everybody was kind of in the same box. Basically, you're stage 4, chemo, until you do not tolerate more chemo or you don't respond more chemo, and then hospice. I think that nowadays has totally, completely changed. Thank you to the target therapy, to the immunotherapy, that I know that there's going to be a specific talk about that, but also thanks to the radiation therapy, because in the past, to send patients for radiation therapy for palliative treatment was basically putting in the balance side effects from 5, 10, 15 days of radiation therapy for whatever was the metastasis in the bone, in the liver, in the lung, even in the abdomen. So the side effects in a very debilitated patient was not the best idea to put them through radiation with a lot of side effects. But nowadays we have the stereotactic radiation therapy that by definition is only 1, 3, or 5 treatments with a very sophisticated machines that I'm not going to go over the different brands, but just in South Florida, pretty much every big hospital, academic hospital, university hospitals, or even community hospital has potential to offer the stereotactic radiation therapy. Is a very sophisticated way to treat only the target without preventing the spread of the dose in other organs. So for those patients that they are the subset of patients that has limited number of metastases, we call it oligometastatic disease. And for those patients, we offer in combination with either chemo and immunotherapy, the stereotactic radiation therapy, and basically it's kind of ridiculous, but it's pretty much no side effects. It's like doing surgery with minimal or no side effects. So I think that the combination of these 2 treatments has made a big difference in this subset of patients of stage 4, not only to palliate pain or pathological fractures or rapidly growing tumors or obstructive pneumonia, or you name it, depending wherever the metastasis is located. But we know that the benefit of treating with radiation in these specific cases with limited metastasis, not only impacting the quality of life, but also in the local control of that site of metastasis. And we're seeing now trials that translates in overall survival for the patient. So I think that overall there's a big role of radiation therapy for metastatic cases.
Great, thank you. They talk about tattoos. Can you talk a little bit about, Dr. Naik, what are the tattoos and how are they used in radiotherapy?
The tattoo. Oh, I apologize. The tattoos are just basically a little bit of ink that it's really with a little needle that goes, and usually one's given right in the middle, and then one's given on each side, and people line up to lasers, and this usually means that when a patient gets set up for their daily treatment, they initially get aligned to their tattoos using the lasers. But like I said, they're there mostly for alignment, making sure a patient's level is not rotated. But in addition to that now, most centers are now sort of doing what we call either a cone beam CT or taking I call it like a fuzzy, it's like someone who doesn't wear glasses where I can see things and I can see how things are lined up, but I can't always necessarily see if there's like a tumor there per se. But it gets a patient much more accurately lined up for their daily treatment. And so that's like a first step using the tattoos. And then now we have got even more finer technology to make sure that as the patients are getting set up better daily for the treatment, we can minimize sort of a safety net margin that we need to treat as they go through treatment and hopefully use that to minimize side effects.
Great. Thank you. Thank you. We have a question in the audience.
Okay. Yes, I'm a gastric cancer survivor, and forgive me if I've missed and didn't register some of this information, but when I first was diagnosed, I wasn't ever given an option for radiation. What criteria is used to determine whether to apply radiation first or chemo, or does that make sense?
Yeah, so as I kind of wanted to briefly mention as I went through that, there's basically, in a sense, almost two different paradigms in how gastric cancer is treated. And nowadays, if people up front get a diagnosis of gastric cancer, a lot more patients are being treated with chemotherapy up front, then having surgery. And then if people are having good response, they're not necessarily always getting radiation treatment after surgery. For patients that sometimes have upfront surgery and everything gets taken out at the time of the diagnosis, we sometimes see risk factors based on an individual's pathology report where we may think that radiation is helpful to reduce things to come back in this area, but it's not always right or wrong for a patient to not get or get radiation treatment. And so oftentimes these are good discussions to have between a medical oncologist, a radiation oncologist, and the surgeon. And the more people are communicating or having multidisciplinary discussions like that, you get basically a better customized plan.
Hey, please go ahead, Dr. Patera.
I just want to add that this could be a debate forever, who gets radiation, who doesn't get radiation, because even in our multidisciplinary tumor boards that we present, ideally every single case that is going to be treated just for the fairness of best treatment for that patient, we don't even get in agreement sometimes. Typically, radiation has a bad reputation because the side effects that we cause to the patient, and as I said, the patient comes from surgery, comes from chemotherapy, many times hardly, trying to recover from the point of view of nutrition. So here we go with radiation causing more fatigue, tiredness, some nausea, sometimes even vomiting. In the other hand, also hand-to-hand with the chemotherapy, sometimes lowering the blood counts. So we don't really have a good reputation. What we cannot forget is that radiation has changed through the past 15 or 20 years tremendously. We move from treating patients with only 2 fields or 4 fields of radiation therapy, what we call AP, anterior and posterior field and lateral, to very sophisticated techniques that basically sounds like a alphabet soup that we call rapid arc. We have IGRT, image-guided radiation therapy, IMRT, intensity-modulated radiation therapy. The technology has changed so much that translates in less side effects for the patient, better targeting of whatever we want decided to target, lymph nodes or tumor bed after the gastrectomy in this case, and less side effects and better quality for the patient, better quality of life. So I really think that we should be tailoring when we see a patient, which patients benefit to start with the chemotherapy up front, then go for surgery, then go for chemoradiation therapy, or chemo, surgery, chemo, or no neoadjuvant therapy up front, only surgery. So I think that even if you are stage 1, 2, 3, or 4, I think that case by case, we cannot forget that we have to look at the patient first, what is the performance of the patient, and then start looking and trying to figure out what is the staging of the patient, because patients are different. And even if you could have a very sick patient that is the stage 1, or a very healthy, like we were listening, very healthy stage 4 that is ready to fight for years the disease. And luckily, I think, again, and I don't want to repeat too much, but I think that stage 4 now has a big hope for maybe in the future for even cure.
Thank you, Dr. Botero. I'd like to open it now, since we're in short time, to our patients. So Pat, can you please tell me a little bit about, very short, your experience when you received radiation and what were your side effects, and any tips you might have for patients? Very short, please.
Yes, the issue I had was after radiation. You, as the doctor said, cook continually for 6 or 8 weeks afterwards before the side effects take away. So that was my issue.
No, and I think that's one of the, as you know, we looked at one of those early papers looking at the sort of the risk of long-term side effects, and so we try to do these things to minimize that. But I always tell people, when you finish your treatment on, say, a Friday, you're not going to feel like everything goes away over the weekend. It takes sometimes, depending on what people's experience, 10 days, a couple weeks before you sort of go over the hill and then start to get better and better and better. But it takes a little bit of time, and a lot of time and support to get people better through any course of treatment.
Thank you. Thank you. Joan?
I had chemo before surgery. I had chemo after surgery. And then I had chemo and radiation. And the reason was because my report from surgery was not good. On one side, when they removed my total stomach, I had, they did not get a clear margin where the esophagus is. And so he said he took out 98% of the cancer cells, but with signet ring cell, there are those microscopic cells that were still left. So thus I had to be tattooed, not the tattoo I would like to have, but I had to be tattooed. And for me, radiation was the worst part of all my treatment. They told me I would not feel anything, maybe 2 weeks or 3 weeks down the line, because I had 5 weeks of radiation. Day one, I was in pain. And that was till today. So I was radiated in a very large area because of my cancer, straight across my stomach, up my esophagus. And I've experienced pain. I keep a log. I keep a log of everything. And the pain never went away. And not only pain, but I had fatigue that was extreme fatigue. That did go away. I just have a little fatigue now. But it's the pain and also the loss of weight. I went from a size 10 to a size 0. And that was during my radiation. So.
Just want to add, again, we're the bad in general, and maybe because we are also by the end of the road, when we receive the patient already have surgery, has chemotherapy, and that's kind of a cumulative, so you're putting in the top of this patient that is not doing the best of the performance, is still trying to survive, trying to take, the nose out of the water and trying to survive, and then we come with the radiation. To begin with, as I said, technology has changed a lot. Secondly, you need to work as a team, meaning a very good communication as a physician, not only with the medical oncology, with the surgeons, but also with the other part of the team that is extremely important, your nurses, basically for swallowing therapy, nutritionists, psychologists, everything that we can add to the patient comfort. Even sometimes if it takes, one of the most common side effects, as you said, from day one is discomfort and even severe nausea. So it's like a feeling pregnant with triple kids from day one to the end of the treatment. So those patients like you requires a lot of support. Basically, even sometimes IV fluids every second or every third day of treatment when they are not eating. Don't wait until they crash to try to do something for them. So I think that the support and working as a team, I think that is very, very important, and that's something that the patient needs to consider when they are looking for where to go for treatment. This is not an easy treatment. Radiation in general is not an easy treatment for any patient, but specifically for GI tumors, it's not an easy treatment. And we're talking about the typical radiation to the tumor bed after gastrectomy. Again, we are not talking about treatment for metastasis that I mentioned is a totally different treatment. Those are really minimal side effects. But in your case, you're the typical case that, we physician have to look at the patient and say from day one, most likely you're going to feel bad. You're going to be sick for, 4 or 5 weeks, but there's a light in the other side of the tunnel.
Thank you very much for the comments, and we're out of time. So thank you very much to the panel. I appreciate it. Thank you.